There's 3 BTK inhibitors that are currently marketed for different indications. We have Ibrutinib, which was the first approved version, Acalabrutinib, which is approved after that, and now Zanubrutinib. There was some interesting data recently presented comparing Acalabrutinib and Ibrutinib sort of head-to-head in the relapse setting. And I think that sort of study gave us a good idea of what are the long-term toxicities. Most of them are cardiovascular in nature, with higher rates of atrial fibrillation and hypertension with Ibrutinib. This was improved with Acalabrutinib, but clearly in both drugs, that still remains a toxicity. For drugs like BTK inhibitors, which are often continued until progression, I think it's important to develop drugs like LOXO-305 that may minimize those cardiovascular toxicities altogether, especially when we think about the patient population we're treating, which is often older patients that already have often cardiac comorbid conditions that result just from being of advanced age. So, I think the toxicities are definitely well defined. There are ways to deal with those toxicities. People will do interruptions of drug or manage the complication with cardiac medications, such as controlling the blood pressure or rate controlling the atrial fibrillation. The other major complication with the irreversible covalent inhibitors is bleeding. Again, that seems to be a little bit less with the Acalabrutinib and the second generation drugs. However, we do think that this might be even better with drugs like LOXO-305, which saw very low rates of bleeding complications.